Hello and welcome to Slide Review. So today we are going over prostate and testicular lesions to finish up our fourth session of the genitourinary system. And as always, we start with our standard disclaimer. And just a reminder, any questions, comments, things that you think were unclear, things you'd like to see, please let us know in the comments, either on YouTube or you can reach out to us on Twitter. We always have our Twitter handles below, as well as a link to all our videos. Okay, so let's get started right into things with case one. And the first thing we see is that it has a very pink appearance to it. This area looks rather nodular. And this really is what's catching our eye. Let's just go down and take a look at things. Now that, again, that nodular appearance tells us that this is, whatever this is well circumscribed. We can see that indeed it is very pink. Just want to zoom in on this interstitial component a little bit. And what we can see is that, there's some collagen, maybe it's a little on the fibrotic end, a little more than we would definitely anticipate seeing in the prostate as well. And if we look at our prostate glands themselves, what we can see, maybe easier if I go to low power, is that the prostate likes to have a very lobular appearance, very much similar to breast, right? So we expect seeing lobular arrangements. You would be concerned if you were seeing things that looked a little more linear. And if we go in on any of these areas, we can see that we have our luminal cells. There is a double layer where we have the luminal cells, the basal cells, and the basal cell layer isn't always super obvious, particularly on H&E, and that's why we, of course, have basal cell stains that are more specific for basal cells and wouldn't stain your luminal cells. In areas like this, we can see that, again, there's just a lot of stroma. Nothing really looks too angry, though. We're not seeing inflammatory infiltrates, which, again, the prostate, just like any other tissue, can have inflammatory reactions. Having this little bit of lymphocytic infiltrate is totally fine. We worry more if we're seeing neutrophils actually in prostate. So again, these little bits of lymphocytic cells are totally acceptable. And again, these look benign. There's a little bit of maybe proteinaceous debris. It's kind of this schmutz that's inside cells. Oops, and I took this out of full view. Just thinking about it. But these cells are, sorry, these glands are a little more simple. And this is just more like cellular debris. For a multitude of reasons. So this is really our lesion, again, extremely well circumscribed. We have this dense cellular, quite cellular actually, stroma that looks maybe slightly fibrotic with more of this pink collagen in there. And there is some complexity to some of these glands. And it just looks like maybe there's more glands than we would expect. So with this, you should probably be in the adenosis range, in particular because of all the dense collagen and hypercellularity in the stroma. I would be within the sclerosing adenosis area of adenosis, and that's exactly what this is. So this is everything listed for adenosis, but I think this case lends itself far more towards the sclerosing adenosis end of that spectrum. So we see this in anywhere from about 1% up to a fifth of TURP specimens, and TURP stands for transurethral resections of prostate. So that's done via cystoscopy. And we see this in a third of our radical prostatectomy. So it's relatively common. We don't see it all the time in core needle biopsies. And remember, core needle biopsies are extremely small. And we don't really sample transition zone, right? Our core needle biopsies are typically taken perirectal or transanal. So from there, you're more likely to get little bits of like GI tissue in with your biopsies than you are to necessarily get adenosis. This is often referred to as atypical adenomatous hyperplasia or AAH as well, and patients are generally asymptomatic from this. They don't know that something's going on, and it's not necessarily something that you can feel. There's no growths to really associate with adenosis. And microscopically, for plain adenosis, you'd expect to see very well circumscribed lesions with small to medium glands in the transition zone. And it's usually mixed in with BPH or benign prostatic hyperplasia. You can see here in the pictures, just lots and lots of glands. There may be infiltrations with surrounding stroma. They can merge with surrounding glands, and that usually happens at the periphery of the lesion. You wouldn't anticipate that being in the center of the lesion. And in the center of these lesions, let's go back to this. So you can see these dilated areas. So these are more likely to be the parent glands that are being compressed and then dilating by all this proliferation of glandular epithelium. But they should look very similar to your surrounding glands, and your acinar cells will have relatively clear cytoplasm. I know these are showing more eosinophilic cytoplasm, and you shouldn't really see nucleoli. Your basement layer can be fragmented or absent, and you may see, again, these crystalloids, this amorphous eosinophilic secretions, which we definitely saw quite a bit of that. For amylacia, we didn't see anything that looked like that to me, and we didn't appreciate mucin. When we're in the sclerosing adenosis realm, which is where I think our case really fit, we have this very densely fibrotic cellular stroma, which we did see, and you may or may not see thickened basement membrane or hyalinized stroma right around the glands, and not really appreciable in our case. The glands themselves tend to be relatively poorly formed as well as individual cells. So again, we had all those normal, somewhat hyperplastic glands, and then we had glands that were kind of just saying they're not really looking like much. But we could appreciate that basal cell layer. And again, if you want to find your basal cell layers, we do have stains for that. And speaking of stains, so your basal cell markers are not just limited to things like P63, your high molecular weight cytokeratins, which that's what 34 beta E12 is. It's a high molecular weight cytokeratin. Sorry. You can also try CK56, and it may or may not stain with S100 as well as calponin. Lyme occurs usually focal, but it can be diffuse in very rare situations. And if you were tempted to try ERG or ERG, that's typically going to be negative. So your differential in these cases, and again, this one just gives you kind of more like the crystalloids. Here's more of that amorphous schmutz. Includes things like our BPH, sclerosing adenosis. Well, our case kind of looked more like sclerosing adenosis than regular adenosis. You can also think about things like mesonephric remnants, as well as low-grade adenocarcinoma. There's no treatment for it because, again, these patients are asymptomatic. They don't know that something's going on. And there's extremely weak evidence that these are actually pre-neoplastic lesions with transitions to a low-grade adenocarcinoma. But for the most part, we consider adenosis and sclerosing adenosis to be benign lesions. Case 2. So again, we see something somewhat similar where we have relatively nodular areas. This area kind of catches your eye a bit because it's very blue. Everything else seems extremely pink. And we can tell that this is a prostatectomy specimen because we have inked outside surface, we have fat, and these very large vessels. But this is really what's catching my eye. I think this is probably some hyperplastic glands, maybe a little bit of nodular hyperplasia. Well, let's just go ahead and see what this blue stuff looks like. Okay, and what we see with this is that all these cells look extremely similar. They're all very blue. They all have about maybe scant to moderate cytoplasm, but obviously the luminal cells what look like luminal cells. I'm not sure if they really are. Look like they have a little more. And we kind of have this almost like punched out colander or cribiform type appearance. See, that's like a perfect circle. And we're starting to see more of these around here. Maybe trying to be calcifications. Okay, this all looks very similar. So this very blue appearance, that's towards the basal cells. We do have some areas for sure that have intact luminal cells. Let's see, here's a good example actually. So you can see areas like this where it's a completely solid nest or solid knot of those basal type cells. So hopefully at this point, you're at least in the hyperplastic range. And let's just take a look at the rest of our case, because this looks a little different here. So just take a look at it. It looks different, but some things also look the same, right? Like here we have this sort of cribiform thing. This still looks kind of cribiform here as well. And one thing that's also maybe a little different is some of these cells look like maybe they have cytoplasmic clearing. But otherwise very similar, right? We have, it's relatively filling things up. We have cribiform architecture. Difficult, again, to tell if this is all maybe the same process. Let's go over into this area that we weren't so concerned about. We do have some dilated glands. And here you can appreciate more of the normal luminal cells. And again, just kind of getting used to what your prostate looks like. So you have these luminal cells that are very tall, have ample, slightly granular to clear eosinophilic cytoplasm. Maybe some basal cells hanging out here. Again, you can get these areas where it's difficult to tell what's actually a luminal cell versus basal cell, and that is why we do stains as well. This looks just maybe a little more like hyperplastic type glands. It definitely looks different from what we were seeing in the other area of the cell, or of the slide. Okay. So we actually have two different things going on here. No, three if you want to count the hyperplasia on the other side, but we've already gone over the more hyperplastic lesions. So this stuff all here, very basaloid, very blue, this is basal cell hyperplasia. However, because it does have this cribiform architecture, you could veer towards the atypical basal hyperplasia. However, it doesn't really look atypical to me. It's just that cribiform architecture that's a little unusual for basal cell hyperplasia, which either tends to have retention of these luminal cells, which is considered incomplete, or complete, which would be those areas where we had the solid nests. This stuff, however, with its, again, cribriform architecture, that first area I looked at, I think was probably the best as far as giving you better morphology. That's kind of like in these guys. Um, so here we have this hyperplastic lesion. It does still have that cribriform architecture, but you can see it side by side with the basal cells. These are not basal cells. They look a little more like luminal cells, right? And we can't really tell, like maybe these are basal cells here that have just been pulled up with some retraction artifact, but kind of hard to say. Some of the cytoplasm also is a little more clear. So this kind of stuff here falls more into what we would call clear cell cribriform hyperplasia. So there's a couple different things going on. And then if we want to go out further, the sort of nodular hyperplastic lesions as well. So this is more of your more normal appearing prostate, but still within like the epithelial hyperplasia proliferation of that spectrum. So that's why down here we just have basal cell and cribriform hyperplasia. I think those are really the more interesting things for you guys to look at. And these are relatively common lesions, and we see that it increases with age. So when men are around 50 years old, about half of them will have some form of hyperplasia. And when they reach 70 to 90 years old, that actually starts to approach 80 to 90%. We don't really know exactly why this happens. We know it has to do with hormones to some degree, and there are risk factors, including aging and family history. So both of these things being things that you can't control. So we don't really have correlation with things like diet or exercise, obesity, those kinds of things. And these patients will be symptomatic. So they'll complain of LUTS or lower urinary tract symptoms. This really doesn't correlate between the histology and their symptoms. So they could have relatively mild disease that could be causing them lots of problems, and they could have very severe disease that they aren't really saying is bothersome to them. And these are split between obstructive and irritative symptoms. So again, this is all your straining to void, weak flow, dribbling, urgency, all those kinds of things. And how this works is what we have is the transition zone, which surrounds your prostatic urethra. This is where your hyperplasia takes place. So in the normal prostate, this area is relatively small and urethra is happy, everything can flow through just fine. But as this gets enlarged, it actually will compress the urethra, and that's where you get a lot of those symptoms. The nodules themselves are relatively easy to find on gross exam, um, and they can range anywhere from a couple millimeters in size to these really large, bulky masses. And the areas themselves tend to be very firm and white, but they can be spongy, and this is if you get like that cystic dilation like we were seeing in that one area of our slide on the right side of our slide. Okay, so lots of differences between epithelial predominant hyperplasia, stromal predominant, and here we have our basal cell and cribriform hyperplasia. So your epithelial hyperplasia, which again, this was towards the right side of your slide, so your glands were medium in size to large, and they, in our case, had cystic dilation. They tend to be architecturally complex, and they can even have those finger-like projections like we saw in some of the glands. Acinar cells in our case were columnar in the more complex glands, and cuboidals to flatten the cystic areas. And they tend to have this abundant pale eosinophilic cytoplasm, and nuclei are regular with open chromatin. So you can see the open chromatin here. Stromal predominant hyperplasia, which we didn't see, just tends to be this really cellular stroma that is bland. So even though there's a lot going on with it, we're not concerned that maybe this is sarcomatous or anything like that. And you tend to see a lot of capillaries, and these capillaries will all be surrounded by the spindle cells as well, including the very small capillaries will also have collagen or cells around them. And there will be an increase in the smooth muscle component of the stroma, and this really correlates with the size of the nodule. So the bigger the nodule, the more smooth muscle you would expect to see. Your basal cell hyperplasia, which is one of the areas I really wanted to highlight in this case, can show glandular atrophy, in particular when patients have been on androgen ablation therapy. We didn't see that in our case, and again, this is very common, so it doesn't necessarily have to be associated with that. We did see both incomplete as well as complete basal cell hyperplasia, again, whether there's preservation of those luminal acinar cells or solid NAS, solid areas of basal cells. You can see cribriform architecture. We did not see the squamous metaplasia, and we did not see atypia. So again, cribriform architecture pushes you a little towards that atypical basal cell hyperplasia. However, I don't think we had the other features to really go that far. Cribriform hyperplasia is rather unique, where we have, again, glandular component that looks very similar to your epithelial hyperplasia with those medium to large glands, but it has that cribriform architecture, and you can see that clear cytoplasm. The clear cytoplasm was only appreciable in a small component of the cribriform hyperplasia. So in those areas, we would refer to that as clear cell cribriform hyperplasia. But again, it does not have to have clear cytoplasm to be called cribriform hyperplasia. And there's a bunch of other subtypes I included in the handout, so make sure you check that out. If we move on to our immunohistochemistry, so your acinar cells will stain for PSA, PAP, and weak staining with Amaker. Your basal cell stains, which P63, your high molecular weight cytokeratins, those should be negative. And you see the opposite in your basal cells. So whether you had a combined stain or you want to do the two stains, you'd be able to see but appreciate both the acinar cells as well as the basal cells. Your differential obviously is going to include things like your atypical adenomatous hyperplasia. Remember, this is adenosis, a pseudohyperplastic variant of adenocarcinoma, stromal sarcomas and stumps, as well as leiomyoma, leiosarcoma, solitary fibrous tumor, prostate. All these you would think about with stromal predominant hyperplasia. Treatment, so they can do a few things. They can do alpha adrenergic blockers, the 5-alpha reductase inhibitors, but really what helps most is doing a transurethral resection of prostate or TURP, as well as simple prostatectomy or an open prostatectomy. And again, it's benign, but the symptoms can be really troublesome and bothersome to the patients. So here we have some examples of basal cell hyperplasia and another example of cribriform hyperplasia. This obviously does not have the clear cytoplasm, so this is just regular cribriform hyperplasia. And this is just a really nice contrast to see both the incomplete and complete basal cell hyperplasia, which is recapitulated here, incomplete, complete, and here are your normal glands. So you should see that stark contrast. Moving on to malignant lesions of the prostate. So again, this very likely is a resection. We have ink, we have fat, and okay. You can see a little bit of blue in some areas, so let's just quickly go through. And what we see here is a little bit of atrophy where glands are angled. Atrophy itself is not malignant. We do have things like this, okay, where we have very small, poorly formed glands. Really not appreciating that dual layer, right? Looks like one layer. And nucleoli aren't always helpful with this, but if you see multiple, they tend to be at the periphery, not centrally located. Hopefully some of you know where I'm going with this already. So this is a little focus of prostate cancer or acinar adenocarcinoma, which is the most common type. And here I think it's maybe a little more appreciable. So here we have normal glands, okay? And then we have all these abnormal glands just sort of flitting in between. They don't really make much sense. Remember, I told you that prostate is like breast, so it likes to be in lobular configurations. This is not a lobular configuration. It's just kind of going wherever it wants to. And the same thing here. So again, this is prostate cancer mixed in with some atrophy, which can make this very difficult. But recognizing the pattern actually is what helps you most. Here's a little more. And some more over here. Well, in most areas of the body, we tend to think of prostate cancer as being, or sorry, as carcinoma as being large, atypical glands, but in the prostate, actually, it's the reverse. They become very small. So acinar adenocarcinoma or prostate adenocarcinoma, which will be abbreviated as PCA, is the most commonly diagnosed cancer in the US and the second highest incidence of cancer-related deaths. Is the fourth most common cancer worldwide. It tends to affect elderly males with very low incidence in males under the age of 50 years old. But just like our BPH, it increases dramatically with age, and 3/4 of your case are going to be in patients older than 65. And there is this increased incidence as well as increased mortality in African Americans in the US, where they see almost 70% increased incidence and mortality compared to Caucasians, and Asian Americans in the US actually have the lowest incidence of prostate cancer. African Americans also have increased involvement of the anterior prostate, which itself might tend to why they have increased morbidity and mortality related to this, because when you think about where we are biopsying, where a lot of prostate cancer tends to occur is in the posterior aspect of the peripheral zone. So if we have the anterior prostate involved, there's not really great ways to sample that. And that's probably one of the reasons why African Americans tend to be adversely affected by this, is that we just don't have a good method of seeing this. It is related to diet that's rich in red meat. Obesity has a relatively weak association, and there's some familial association with somewhat complex genetics. As I was saying, this tends to occur mostly in the peripheral zone. It can occur in the transitional zone, and most cases will be multifocal with no gross mass lesion, obviously. So what this is showing is a nice nodule that is within the peripheral zone. So here's your urethra, and you can see all these little nodules just kind of going everywhere. On histology, again, here's your large nodule. Here's your urethra, which you can see how it's being compressed by all this BPH. Okay, so remember, BPH also increases with age, and it can be compounding component of trying to determine if there's cancer or not. And then what this is showing here, it's kind of hard to see, but we have all these tiny little glands in here. And this is involving the posterior lateral nerve bundle, which prostate cancer loves to involve nerves, but this is actually extraprostatic extension, or EPE. If you are lucky enough to see a lesion grossly, they tend to be stage T3, Gleason score 8 or more, and at least 1 centimeter in size, and they'll be this case is yellow tan. They can be indurated or homogeneous, and they definitely are more firm than surrounding parenchyma. But what else is firm? BPH can be firm, adenosis can be firm, and well, I shouldn't say adenosis can be firm. You would think that adenosis can be firm, but grossly it doesn't really have anything that you can appreciate. You shouldn't see necrosis or hemorrhage, and you shouldn't have a really well-defined border. It should be somewhat blurred, which is why microscopically the lesions tend to be much bigger than what they are appreciated grossly if you are able to appreciate something. So as we were saying, malignant glands tend to be very small with these rigid, sharp lumina. They can be crowded or compact. You should not see basal cells. Okay, so even if you tried staining, they won't be there. And you may or may not see periglandular clefts or retraction. So there's a little bit of retraction here on a couple of these cases. The cells themselves tend to be very large, but still bland. So even though they're big, they're still bland. And you can see these macronucleoli, which are often peripherally located. Okay, you can see chromatin clearing. So again, you can see how like it's centrally cleared. And you may see some mitotic figures in apoptotic bodies, but you don't really appreciate that too much with prostate. The cells themselves tend to be cuboidal or columnar with amphiphilic, clear or pale granular cytoplasm. And the amphiphilic cytoplasm really is what can help you if it's present. If you're in the transitional zone, the cells can be taller or more columnar. And again, we'll have that clear, pale cytoplasm and may or may not see basal nuclei. So transition zone is something to keep in mind that you don't want to confuse that with carcinoma, but they can look really scary. Intraluminal features, and all these are relatively soft findings. So you can see intraluminal blue mucin, these eosinophilic amorphous secretions, crystalloids, corpora amylaceae are extremely rare. So if you're seeing corpora amylaceae, you might want to think about something else. And high-grade tumors tend to have intraluminal necrosis. So again, all these things we can see in a lot of other lesions. What does help you, though, are the pathognomonic features for malignant glands. Are things like glomerulations, this mucinous fibroplasia, or collagenous micronodules, circumferential perineural intraneural invasion. Remember, I said prostate cancer loves to go to nerves, as well as growth within adipose tissue. So what that means is you need to have the cancer at the same level as adipose. There shouldn't be adipose within your prostate gland, but of course there are always exceptions. So here, the glomerulation, so you can see how it's trying to look like a glomerulus versus your collagenous micronodules, so micronodules. And I just wanted to show these side by side because they can look somewhat similar at low power. So you just, whether or not this is mucinous fibroplasia or tumoral cells. So these are tumor cells. It stains for adenocarcinoma, PSA, PSP, PSMA, and you may or may not get some ERK in there if there's the mutation. Negative stains, so your basal stains. P63, high molecular weight cytokeratins, and there can be cytoplasmic loss of PTEN, again, related to mutations. The mutation to know is the TMPRSS2 ERG gene fusion. This is found in about 50% of prostate cancers will have the fusions with the ETS gene family, and almost all of those will be ERG specifically. The features that typically are associated with this fusion include the blue-tinged intraluminal mucin, cribriform patterns, intraductal spread, micronucleoli, as well as signet ring formation. And this is why this is important. The vast majority of the tumors with at least 3 of these features will have the translocation. However, a quarter of cases without these features will stop the translocation. So again, it is the one to know if you have to know anything about adenocarcinoma. PTEN can be seen in about a third of your cases. And then and PTEN also can occur with that ERG gene fusion. And then we start getting into things that maybe are associated with familial genes or just relatively low percentage. So your SPOP, lots of individual mutational losses and gains, genes. Remember, if we can have signet rings, CDH1, ECAG here, and so you want to always keep that in the back of your mind, the correlation between signet rings, loss of cell cohesion, CDH1, regardless of where you are, that should always be there if you have that association. As well as androgen receptor genes are thought to maybe promote growth in androgen deprived lesions. And there's also talk about petrol pathway being related to both the growth and metastasis of prostate cancer. Differential goes anywhere from, is it reactive, partial atrophy, to high-grade PIN? Is it metastatic? Is it adenosis? So you really, if you weren't sure, stains are your best bet with these. There's lots of different things that they can do, whether they're doing just hormone deprivation. They can do brachytherapy, which is high or low dose radiation treatment directly into the prostate. They can also can do radical prostatectomy with or without pelvic lymph node dissection. There has been talk about the Gleason grade groups, which I've included in your handout. And here, so when we say perineural invasion, it really means circumferential perineural invasion. So here's your nerve in the center. Okay, and adipose invasion, so you can see the fat here, and here are your malignant glands. Okay, that's a lot on prostate cancer, but again, it is very common. There is a lot of information in your handout pertaining to grading, the prognostic grade groups, how you stage it, and I also included pictures of both your pathognomonic features, which are in the presentation here, and there's also pictures of your non-pathognomonic features that we talked about. Okay, so now we're going to move on to testicular lesions, in particular, looking at benign lesions of the testis. So what we can see is that this is very well circumscribed. Looks like it has a stalk here. And maybe some mucin, and probably intact epithelium, but a little hard to tell. And then maybe it looks like some vessels here at low power. So if we go down, we can see that yes, we have vessels. And these cells actually are intact. So they're columnar, kind of hard to tell, but they almost look pseudostratified. Here, but this is definitely columnar epithelium. Also these dilated vessels. And here will be a little better. I'm kind of seeing like this smooth muscle just kind of going around the lesion, but kind of falling apart. So with all these dilated vessels, I wonder if this maybe twisted on itself. So it seems somewhat poorly fixed in some areas where we're getting some drop off. But okay, so we're looking at benign testis. We have this pedunculated appearing lesion that has lots of vessels, smooth muscle proliferation. So this is actually an appendix testis, which is also known as the hydatid of Morgani. And remember, hydatid just refers to anything that's sort of grape-like. And these are common. They're found in most males, actually. And it's a Mullerian duct remnant that can undergo torsion. So when we look at the appendix features, you can have appendix epididymis and appendix testes. So here's the appendix testes. So we can see that they are attached to the tunica albuginea at the upper testicular pole. So again, upper pole, lower pole. And they can be round, oval, they can be pedunculated, and they tend to be between 1 millimeter to 1 centimeter in size. And they can undergo torsion, which can be really painful, and that's probably why we had that case. And so if they're tours, they may appear grossly congested or violaceous, or violaceous means purplish. You may or may not see gross hemorrhage, and you may or may not see necrosis grossly. So microscopically, they have this columnar epithelium, which we can appreciate there, and this fibrovascular core. I think the core was maybe a little more difficult to appreciate, but we definitely had lots of these dilated capillaries around it, and it was surrounded by smooth muscle. It can give a glandular-like appearance if it has surface invaginations, and if it underwent torsion, then we would expect to see things more like hemorrhage and dilated veins. So we definitely had dilated veins. You may or may not see damaged vessels and coagulative necrosis associated with that. You may or may not see things like granulation tissue, fibrosis, or interstitial inflammation. And if you see inflammation, you would expect it to be lymphocytic. That would be the most common. There's no real IHC or molecular for you to know. Again, 90% of males have them, and most of them don't have a problem with it. Your differential includes a lot of things that can cause testicular pain, as well as hemorrhage. You would also want to think about things like germ cell neoplasia in situ, systemic vasculitides. So this would be things like maybe lupus or Wegener's granulomatosis, as well as lymphoma. For treatment, they leave them alone unless they undergo torsion. Obviously, we don't want patients to be in pain. So if they undergo torsion, we're going to take that out, because first it's going to torse and then it's going to die off, and you wouldn't want necrotic tissue staying in your patient. And these are completely benign. So appendix testis, something that most males will have, but most of them won't have to deal with in their lifetime. Moving on to the malignant lesions, and some of these can be really challenging. So this first one we can see is extremely well circumscribed. Looks like this is normal tubules here. It's extremely blue and maybe septated. See these areas. So if we go down, hopefully some of you know right away what this is. We have lots of lymphocytes, and lymphocytes are definitely within these septations. So we were correct about those. And the cells themselves, I think there's some retraction. The cells are somewhat monotonous, even though they're large. Not seeing things that look really atypical. And where there is cytoplasm, it is clear. Okay, we're not going to spend too much time on this. There's a nucleoli. There are some nucleoli. This is relatively bland. Not having mitotic figures jump out at us. Again, lymphocytes within these fibroseptae. So what are we looking at? Hopefully you know where we're going with this. This is a seminoma. So this is your most common malignant testicular germ cell tumor. And typically we're going to have germ cell tumor, just GCT, in the presentation as well as your handout. It accounts for about 50% of tumors within the testis, and this is the same entity is germinoma if it's extragonadal, dysgerminoma when it occurs in the ovary. So the exact same process. This is just seminoma when it's in the testis. It tends to occur in middle-aged adults. It's very uncommon to see in older adults and extremely rare in children. And they tend to be older than the non-seminomatous germ cell tumor. So non-seminomatous just means not seminoma. They are typically painless testicular masses, and that's about 3/4 of your patients. But some patients can have scrotal pain. They might have those B symptoms, like whether it's fever, malaise. 4% of them will be completely asymptomatic, so you need to keep that in mind. Extremely rare presentations would be gynecomastia as well as exophthalmos. Serum markers that we would anticipate for seminoma include increased LDH as well as beta HCG. You should not have an increase in alpha-fetoprotein and no increase in AFP if it's pure seminoma. Remember, we can have a lot of mixed tumors in the testis, so pure seminoma does not have increased AFP. Most of them are going to be unilateral, but about 2% will be bilateral, and this is more common than what's seen in the non-seminomatous GCT. Less than 5% will have spermatic cord involvement, and they tend to be very well circumscribed, homogeneous lesions. They may or may not be lobated in appearance, like maybe a little bit of lobulation. And 90% of them will be confined to the testes. So again, owing in part that we have relatively low spermatic cord involvement. And what you see here is really what they look like, this creamy, fleshy, firm or bulging type appearance. You shouldn't see hemorrhage or necrosis. If you do, you want to think about mixed germ cell tumors. But if you have a really large tumor, then you can see this geographic infarct type necrosis. Sorry, this is not necrosis. I realized I was moving the mouse off. And if you have hemorrhage, it'll be this really fine punctate type hemorrhage. That's usually in areas of syncytiotrophoblasts. On average, these are going to be 5 centimeters or about 2 inches in size, but they can range up to 2 feet in size. So you really, but they can range up to 24 centimeters in size. Microscopically, there's a lot of different patterns that can be associated with this, but you tend to see these solid sheets or nests of cells that are separated by these fibrous septae. And within the fibrous septae are going to be your lymphocytes. And yes, that's also something important to note, is that the septae are relatively regular. Your tumors are for the most part evenly spread. And you can actually see germinal centers with the lymphocytic proliferation. So don't be worried if you see that. More than half of the cases will have these very ill-defined granulomatous formations. And if they're really extensive, it can be difficult to identify your tumor cells. And remember, we have things like granulomatous orchitis and things like that. So it can be really challenging if that's an extensive component. If you have areas of fibrosis, sclerosis, or scar formation, if they're prominent and you're not really seeing tumor cells, we call that burnt out seminoma. And rarely you can see extensive hemorrhage or necrosis. You may or may not see these syncytiotrophoblasts giant cells in areas of hemorrhage. So again, these would be multinucleated. And you may or may not see germ cell neoplasia in situ or GCNIS. And there is an entire section on GCNIS within the handout. The cells themselves tend to be large, polygonal, with very abundant clear cytoplasm. You can have prominent cellular membranes, which this shows. The case that we had, it was kind of falling apart, so I don't think this was as well appreciated. Which that's probably a fixation issue. And you shouldn't really have things like nuclear overlapping, and your nuclei, even though they're large, again, they're bland, and you may or may not see prominent nucleoli, but 1 to 2. So you wouldn't see like multiple peripheral nucleoli like we saw with prostate cancer. You may or may not see mitotic activity, and if you have a lot of these big cells, high NC ratio, and lots of mitotic activities, then we think about things like anaplastic seminoma and some very rare appearances to keep in mind. Your stains, so OX34, SAL4, SOC17, podoplanin, all these things are going to keep making appearances within these germ cell tumors. So I do encourage you to take a look at them. If you find a visual chart more helpful, then maybe that's something to create. Stains, typically your keratins will be negative, EMA, EFP, again, if this is pure, beta HCG, inhibit A, CD30, glypican-3, SOX2, so things that would help you figure out other germ cell tumors and other tumors are things to keep in mind. The molecular is somewhat complex, but the things to keep in mind would be mutations within KIT, TP53, KRAS, NRAS, as well as this gain of 12P and DNA hypermethylation. Your differential is pretty much other germ cell tumors, lymphoma, spermatocytic tumor, as well as monophasic choriocarcinoma, sertoli cell tumor, which is extremely rare, and that non-specific granulomatous orchitis. Remember, if that granulomatous formation is really prominent, this is something that you'd want to differentiate from. Treatment, they tend to do a radical inguinal orchiectomy with or without retroperitoneal lymph node dissection. That's what RPLND is, retroperitoneal lymph node dissection. And surveillance, they may or may not do radiation. They may or may not do chemo. And chemotherapy is adjuvant chemo. Prognosis, so if they are stage 1 or 2, they have a 98% cure rate. So very excellent cure rate for this if they can catch it early enough. Again, you can see lymphoid follicles, so don't let that scare you. This is the seminoma. You can have intratubular growth, which is what this is. We can have germ cell neoplasia in situ and just conventional. This is a cytology smear. So what we can see here is that at first you might think, oh, are these apoptotic bodies because they're so small, but these are actually the lymphocytes. And then these larger cells with that macronucleoli, these are your seminoma cells. And just another view of seminoma. Okay. Our next case, so still within the testes. And while this looks relatively bland, this blue area is really where we want to focus our attention, I think. So let's go in here. Right. And what we see here is very different from what we saw with our seminoma. These cells are quite pleomorphic. Okay. We do have, there's some apoptotic bodies kind of sprinkled all over the place. Looks like maybe that might be mitotic there. But wildly pleomorphic, so very different from what we were seeing with seminoma. And a solid proliferation. Here we're seeing a lot of necrosis. There's also no real configuration. Like it kind of just looks like it's kind of percolating through everything. Whereas again, your seminoma really well circumscribed, had those fibrous bands. Anything else that we can really talk about? There is overlap between the cells. Areas even where it almost looks like molding. I don't think it is, but it kind of has that same appearance. Lots of mitotic figures. Just a very ugly looking tumor. So we have this much pleomorphism. What we're looking at becomes a somewhat smaller list. Look at the size of this cell. So this is actually an embryonal carcinoma, which is the second most common pure testicular germ cell tumor after seminoma. It accounts for about 10% of your tumors. So remember, your seminoma is 50%. This is another 10%. And it's more commonly seen as a mixed tumor with other components, and this is about 80% of your cases. The younger age range in seminoma, 15 to 35. Remember, our seminoma was about 35 to 45. This does not occur in young children, infants. So by young children, we mean less than 15 years old. And it's really rare to see in someone older than 40. These patients will have testicular mass or swelling. And if they have features like back pain, dyspnea, and neurologic symptoms, then we would worry about metastasis. They may or may not have elevated serum levels of LDH, PLP, and CA19-9. And in pure embryonal carcinoma, that's what EC is, your AFP and beta HCG are not elevated. Okay. These are very poorly circumscribed masses. Like here, we can't tell where it begins, where it ends. Average of 2.5 centimeters or 1 inch in size. And they're usually smaller than seminoma or these mixed tumors. And they have this very variable cut surface. You can see areas where it's hemorrhagic, areas where maybe it's a little yellowish, areas where it's more fleshy and bulging. And they tend to have large areas of hemorrhage and necrosis. Patterns that there's lots of patterns associated with this, just kind of like everything, but your solid and papillary are two of the common that you could see. Our case was solid. Okay, and glandular was the other common potential pattern, which we didn't see. Again, our case was solid. You can see this applique pattern. Applique pattern just means that you have this solid architectural pattern that's basically surrounded by necrosis or degenerating tumor cells, so apoptotic bodies and stuff like that. So it gives this appearance like the carcinoma is applied on top of the testicular tissue. So that's the applique. Hemorrhage and necrosis may be seen and are very common symptoms. You may also see lymphocytic infiltrates as well as rare granulomatous reactions. Remember, we also have granulomas in seminoma. Frequent involvement of reedy testes, epididymis, and spermatocord invasion, as well as lymphovascular invasion. Remember, spermatocord invasion happened in less than 5% of seminomas, so this is extremely common and is most common in embryonal carcinoma than the other germ cell tumors. You may or may not, again, see GCNIS, which you often will. You can see intratubular extension of carcinoma with commutotype necrosis as well as calcifications. The cells themselves, like we were talking about, very large. They are cohesive, very pleomorphic cells, high pleomorphism with this amphiphilic cytoplasm. So amphiphilic, again, meaning purplish. And they have indistinct cell membranes. Remember, our seminoma had very distinct cell membranes. You will see mitotic activities in apoptosis as well as geographic necrosis. These things were all uncommon, very unusual to see in seminoma. We have syncytial growth or sheets of growth. You will have nuclear overlapping, uneven cellular distribution, coarse or vesicular chromatin, so coarse and vesicular, so you can appreciate that here. And if you have glandular EC, you would expect to see columnar cells with vacuoles. I think what they're trying to show, like here, are some of the vacuoles. And they can either be subnuclear or supernuclear. Your stains, so your keratins will be positive in this. CD30, OX34, PLAP, SAL4, SOX2, and you may or may not see focal positivity for HCG and AFP. So remember how this is very different from seminoma. Negative stains, EMA, MUC1, CA, CK20, SOX17, glypican-3, alpha-inhibin, and calretinin. The molecular, so there are some things that are very similar with your seminoma. Your DNM T3B is a thing to know, and there's some other mutations here. The Plow5F1 is something that's also seen with your GCNIS. Differential, you would think about anaplastic variant of seminoma. Again, we shouldn't see pleomorphism in seminoma unless it's the anaplastic variant. Spermatocytic tumor, again, anaplastic variant. Yolk sac tumor, metastatic carcinoma, again, because of the cytokeratin positivity. You think about lymphoma, as well as your sex cord stromal tumors. Treatment, they tend to give either chemo by itself or in combination with a retroperitoneal lymph node dissection and radical inguinal lumpectomy. This has the poorest prognosis of all your germ cell tumors, including seminoma, and its cure rate is actually really high, similar to seminoma for stage 1. It does drop off a little bit for bulky stage 2, as well as stage 3 to 70 to 85%. Here, just showing you some more of the patterns. Your papillary type pattern again, your complex glandular pattern, and the arrows here are pointing at mitotic figures. Here, looks like it's pointing at an apoptotic body. Looking at this case, we can see that we have all this blue This looks like normal soft tissue over here. There's maybe some vessels. So let's just go in. Okay. And what we're seeing is, again, a different pattern. And what we're really appreciating in the first two cases. So what we have are these very slender septae that surround all these tumor cells. And the tumor cells themselves look relatively bland. They're somewhat epithelioid in appearance. Cytoplasm is clear, maybe somewhat vacuolated in appearance. Some areas it's more pale and eosinophilic. And there's a little bit of pleomorphism, you know, like some of them are a little more round, some of them maybe a little more triangular, but they all look like they're within the same family. Okay, so some of the other things that we want to look at, besides this pattern, which for the most part looks maybe a little more on the reticular side, microcystic, some areas here where it looks more cystic. And some of you might know where I'm going with that already. But these are things that you want to look at. This is what's known as a Schiller-Duval body. And a Schiller-Duval body means that we have these capillaries that are surrounded by tumor cells. And then we have this space or cleft around them, followed by more tumor cells. So it has this papillary type appearance, but it's having really papillary type projections with the space and then more tumor that is unique to this type of tumor. So we've gone ahead and annotated this so that these are easier for you to find. If we zoom out, so you can see that I've added in there that says Schiller-Duval bodies. So the Schiller-Duval bodies are one thing that's indicative of the endodermal sinus pattern. They don't have to be seen all the time with this type of lesion. And there is one other feature that you can see with multiple patterns that I've also annotated on this slide as well. So if we just go to that annotation, which is really close to this area, I'll zoom us in and once this loads. So what this is showing you here are these eosinophilic hyaline globules, and these can be intercellular or extracellular. And these are commonly seen with the microcystic reticular pattern, but you can really see them in multiple patterns. So if we put all this together, what we are left with is a yolk sac tumor. So yolk sac tumor used to be called endodermal sinus tumor, EST, or YST for yolk sac tumor. So if you see that elsewhere, just like GCT, that's what we're referring to. So this is most commonly seen in your infants and your young children, and again, young children being less than 15 years old. And unlike other germ cell tumors, there's no association with cryptorchism in 3/4 of these cases. So you can see it, but it's not something you would commonly associate. To see a pure yolk sac tumor where it's only yolk sac tumor, this is extremely rare to see in adults. And it's usually present as a mixed germ cell tumor in almost half your cases, or it presents after the patient's had chemotherapy. So this would be a recurrence with yolk sac tumor features. If you're looking at pediatric yolk sac tumor, these tend to be around the 1.5 year range. If they're adults, they're still about 10 years younger than seminoma, so 25 to 35 compared to like that 35 to 45-year-old range. And the patients are asymptomatic, but they will have rapid testicular enlargement, and almost all of them will have increased AFP. So that's something to think about in contrast to our other germ cell tumors where you may or may not see that increase in AFP. Grossly, these are very similar to almost everything else that we've seen in this area, where they'll be non-encapsulated, softer fur,
relatively homogeneous, but what makes them a little different is that they tend to have this myxoid or gelatinous type cut surface. And usually in adults, they're going to be heterogeneous. So areas with hemorrhage and necrosis would make you think of mixed germ cell tumor. This would probably be your yolk sac element. And remember, for hemorrhage, you'd probably favor things like embryonal, but it could be other germ cell tumor elements as well. And this is just a low power image of yolk sac tumor. As with a lot of other tumors that we've seen today, yolk sac tumor has a lot of different growth patterns, so I've added those into your handout so you can take a look at those. Your microcystic reticular pattern is the most common, and there are elements of microcystic and reticular pattern in the case that we had, where you have these relatively thin cords that form these tubules. So you can see the tubules kind of forming here. And you have these spaces in between, and you can have vacuoles or this sieve-like appearance where you have the spaces in between the tumoral cells. The endodermal sinus pattern is best known for having the Schiller-Duval bodies, which again are those central vibrovascular cores or those central capillaries, which are lined by your tumoral cells. And then you have that cystic space followed by more tumor. And it really creates this labyrinthine like space or maze-like spaces. And then one of the other things that we can see that we also, so the Schiller-Duval bodies have annotations, and the hyaline globules also have an annotation on that slide just to make it a little easier for you guys to find, but they are everywhere within the slide. And they're seen in the microcystic reticular pattern, solid as well as hepatoid. And because we have that mixed growth pattern where we have some endodermal sinus, some microcystic reticular pattern, in some areas that even look maybe a little more solid, it's not unusual to find those. The tumor cells themselves tend to be either bland and epithelioid with these either clear vacuolated or pale eosinophilic cytoplasm, which we saw when we're looking at things particularly like endodermal sinus pattern where we have those Schiller-Duval bodies. Then you're looking at cuboidal columnar or flattened, sometimes even spindled cells can be seen in these tumors with mild nuclear atypia. So you shouldn't see extreme pleomorphism. You can have a little bit of nuclear overlapping, and remember, we did not see nuclear overlapping with seminoma, whereas it was really common with our embryonal carcinoma. Again, we're going back to indistinct cell borders, so again, similar to embryonal, and they are very, when it says deceptively benign in appearance, usually what this means is they're saying that, like, even though it looks bland, this is something that you really want to pay attention to. Because remember, we're not looking for a lot of nuclear atypia. For your stains, again, your keratins are going to be positive, AFP, because remember, almost all patients are going to have elevated serum AFP, glypican-3, cell-4, and you may see some variable staining with PLAP as well as SOX17. Your PAS with diastase is going to stain those hyaline globules. So if you're having difficulty identifying those, PASD is going to be helpful there. And then your other stains that we use to differentiate out our other germ cell tumors will be negative. For molecular, again, a very lengthy list. NRAS, AFP being the two big ones to pay attention to. And you can also see things like your KRAS, BRAF, that gain of 12P that we've seen in everything in this area so far today, as well as that DNA hypermethylation. Your differential will include things like embryonal carcinoma, seminoma, Leydig cell tumor, and radiotestate hyperplasia. Remember, radiotestate hyperplasia can also have hyaline globules, so that's something to keep in the back of your mind. Treatment varies between adults and children. For children, if it's stage 1, they can get away with doing a radical inguinal orchiectomy and being done. Cisplatin-based chemo is typically done for either high stage recurrence or metastasis in children. For adults, they're going to do a radical inguinal orchiectomy with or without the retroperitoneal lymph node dissection. Remember, RPL&D is retroperitoneal lymph node dissection. And they'll look at doing cisplatin-based chemo for metastasis. Prognosis for these is related more to your clinical stage, lymphovascular invasion, and serum AFP levels. And children overall tend to have a better prognosis. So here again, we have an example of a Schiller-Duvall body. Here's that fibrovascular core here, tumoral cells, cleft, and then you have more tumoral cells around it. And here I just wanted to show you a couple more patterns. So again, in our case, I think we had some areas that also imparted more of a solid appearance. And then this I thought was just a really nice comparison between embryonal carcinoma and yolk sac tumor. So we can see yolk sac tumor, even though there's no lost cells, they're not as pleomorphic as the embryonal carcinoma, which also has this amphiphilic cytoplasm. Okay, so if you're seeing something that's wildly pleomorphic, has lots of mitotic activity, you would lean more towards embryonal carcinoma than yolk sac tumor. But remember, if you have an adult patient, it's far more common for these to be mixed tumors than pure. Moving on to our last case of the day. So again, we are still within testicular lesions, and we can see that this is relatively blue. If you didn't know better, you would almost think maybe we have a section of a lymph node with maybe some germinal type centers, even though they're oddly shaped. So let's just go down and see what we have. Okay. Maybe a tubule here. Kind of looks like a tubule. But when we see our lesion, see how close it'll let us go in. Okay, I guess this is it. So what we have here is this relatively diffuse effacement. It doesn't really matter where we go in this lesion. This is pretty much what you're going to see through all of it. These cells are relatively large, but still somewhat atypical. It's unfortunate that this is the highest power that we can go on. But if we compare them to the red cells that are here, we can see that they're roughly the size of a red cell. So we're in the lymphocytic type range, but they're still somewhat large and somewhat atypical even for lymphocytes. Good amount of mitotic activity. We can see mitotic figures. What we're looking for, and again, you would want a higher power view to really take a look at the nuclear features. Or do we have cleaved cells, which may be here? You can have cells that look more like immunoblasts, and I think we have a few sprinkled throughout here. And you can also have multilobated cells as well. But the idea being that these cells, even though they're relatively large and atypical for lymphocytes, they're still relatively small and disc cohesive. So we're not thinking about things like carcinomas and whatnot. Let's see if we can find any intact testicular tissue. So we're looking for tubules. So if we can find a definite tubule, we might be able to see another feature. It's kind of doing it here. You might have to use your imagination a little bit. So even though there's some effacement of this tubule, what we can see here is we have layering of these tumoral cells going around the tubule. And you could imagine that if you follow these all around, they impart this sort of concentric ring or an onion skinning type appearance, which is what this lesion is known for. Let's see if we can find a better example. So if we look here, you can see more of this concentric type appearance. So this is maybe a little bit of a better onion skinning type appearance. I do have at least one picture of onion skinning to show you so that you can see a good example of that. So what is this? This is lymphoma, and the most common type here is a diffuse large B-cell lymphoma, which is what this is. So diffuse large B-cell lymphomas are the most common. The information in the slides as well as within your handout pertains to lymphomas as a general rule. However, your DLBCL is the most common, so keep that in the back of your mind. So malignant lymphoma itself is rare within the testes and only accounts for 2 to 5% of testicular neoplasms. And primary plasmacytoma has only been reported in a handful of cases. So if you're sure that you have a plasmacytoma, that is a case report that you should write up. It's more common to see malignant lymphoma as secondary involvement rather than primary lymphoma. In patients with multiple myeloma, a secondary plasmacytoma will occur in about 2% of them. And this will be found at autopsy. It'll be clinically occult. So they won't be aware of it prior to death. This tends to occur in our middle-aged adults, average of 56 to 60 years old, so about a 60-year-old male. And half of your testicular tumors in patients that are over 60 are going to be lymphomas. Testicular leukemia is often found via leukemic infiltrate at autopsy, and 40 to 65% of acute leukemias will have an associated leukemic infiltrate at autopsy, as well as 20 to 35% of chronic leukemias. These infiltrates are far more common in children. And as a general rule with lymphomas, plasmacytomas, leukemias involving the testes, the patients will have testicular masses or enlargements. They may have fever, night sweats, as well as weight loss. Apart from the testes, testicular lymphoma really likes to involve CNS, Waldeier's ring, the skin, as well as the lungs. So it has some unusual presentations associated with it. Lymphoma and plasmacytoma tend to be these diffuse lobulated masses that are very fleshy or tan white with a very homogeneous cut surface. So we want to think about seminoma, or you can think about things like spermatocytic seminoma, and these average about 6 centimeters in size. There may or may not be involvement of the epididymis, spermatic cord, or the contralateral testes, so bilateral involvement. And half of your cases will actually involve the epididymis, so you really want to make sure that you're sampling that well. And about a quarter to a third of your cases will be bilateral. Okay, and spermatic cord involvement is really common with this when you compare it to the other germ cell tumors. You may or may not see hemorrhage or necrosis, but if you do, it should be focal, it shouldn't be diffuse. So here we can see a picture of spermatic cord involvement. So you can see the expansion, lobulated expansion of the spermatic cord. Testicular leukemia usually doesn't present with gross abnormalities, but rarely there might be either induration, the testes or scrotum, there might be a palpable mass or testicular enlargement, but you really shouldn't bank on seeing that. Microscopically, lymphomas present as this diffuse interstitial pattern with relative tubule preservation. It maybe not so appreciable in our case. It was difficult to find tubules, but they were there. And we did appreciate the sheet-like or tumoral type growth. Your effacement infiltration of your seminiferous tubules can give your onion skin appearance. And the onion skin appearance is actually best observed with the reticulin stain because it would stain around the layers, so it really gives you a nice appreciation of that. And you may see sclerosis, and when you do see that, that actually portends a favorable prognosis. Again, the most common type is your diffuse large B-cell lymphoma that accounts for 70 to 90% of these lesions. And diffuse large B-cell lymphoma is sheets of large atypical lymphoid cells, and some of them may be cleaved, some of them may be non-cleaved. You can have multilobated cells. You can have cells that look like immunoblasts, as we were talking about. For plasmacytomas and melanomas, you're going to have sheets of variably differentiated but relatively monomorphic plasmacytic cells, plasma cells. And for leukemia, these are going to be similar to lymphomas elsewhere microscopically. And the caveat to leukemias is that often these can be missed and diagnosed as lymphomas when they're actually leukemias. When you compare it to lymphomas, the cells should be smaller, your chromatins should be more evenly dispersed, and you should have less prominent nucleoli, but you're far more likely to have LVI. This should be off 10, not of 10. And rarely you're going to have that seminiferous tubule invasion. So remember, the seminiferous tubule invasion is what gives you the onion skin pattern. So that would be extremely rare with a leukemia. And then this is a list of other lymphomas that you can see. So your stains, a lot of these are common between the lymphomas, your CD45, CD20, variable BCL2, CD10 would be positive if you had a follicular lymphoma. And remember that reticulin can be helpful if you're looking for the onion skin appearance around the seminiferous tubules. For your diffuse large B cell, which again is your non-germinal center B cell like large cell lymphomas, you'd be looking at MUM1 positivity. Your CD10 should be negative, so that it contrasts to your follicular lymphoma. Remember, follicular being germ cell, diffuse large B cell being non-germinal cell. And you should also have a negative BCL6. If you're thinking about plasmacytomas, then CD138 to highlight the plasma cells, as well as monoclonal kappa or lambda light chain is what you should be looking at. Again, that would be kappa or lambda light chain restriction. For leukemias, we'd be looking at lysozyme positivity, your MPO positivity. You can see CD117 or c-KIT positivity and CD68 positivity as well. Your mutations tend to be your MYD88 mutation with CD79B, which is most of your cases. You can see CDKN2A in most of the cases as well. And we can see alterations in PD1, PD2 loci as well. There's loss of 6P, gain of 19q13, and you can see a translocation 1418. So your differential includes all the lymphomas that we were listing before. You'd want to think about your testicular leukemia with regards to diffuse large B-cell lymphoma, as well as that plasmacytoma myeloma. You'd want to think about your other germ cell tumors, particularly seminoma because of the involvement of lymphocytes with seminoma, chronic orchitis, again, Leydig cell tumor, and metastatic tumor. So here, this is very similar to our case where you can see these effaced tubules. And again, the seminiferous tubules, and here is that onion skinning pattern. For treatment, they tend to do a radical orchiectomy for lymphoma and plasmacytoma, and this they tend to do in older patients. They don't necessarily want to do this in someone who's very young. Adjuvant therapy will be very similar to leukemias, whether they're nodal or extranodal elsewhere. And they can also do prophylactic, that's what PPX is prophylactic intrathecal chemotherapy, as well as radiation to the contralateral testes. Now remember, a good number of cases can have bilateral involvement, so you want to consider that. Your prognosis for testicular lymphoma, your early stage tumors tend to have local recurrence, and higher stage lymphomas tend to have leptomeningeal involvement. Remember how I said testicular lymphoma likes to involve the CNS, so that's where this comes in. Your 5-year survival is relatively poor at 37 to 48%, and your 10-year survival also does not bode well at 19 to 27%. Children who have secondary lymphoma, however, do very well with chemotherapy. And only chemotherapy. Remember, orchiectomy is something that we'd consider doing in an older adult. If we're looking at plasmacytomas, primary testicular plasmacytoma is more favorable than patients who have multiple myeloma. So multiple myeloma with secondary involvement of the testis would have poor prognosis. Leukemic involvement gives you an indication that the patient's going to have relapse down the road. And your other prognostic factors that you need to consider is age, because children do well, your overall stage, is there involvement of the epididymis or spermatic cord, and remember the presence of sclerosis gives you a better prognosis. So again, just going back to these slides of diffuse large B-cell lymphoma, and again, that onion skinning pattern around the seminiferous tubules. So that's what we have for this week. We have 10 challenge cases for you to look at, and we'll be back with another video going over those challenge cases. Do spend a bit of time on these cases as well as going over your handout. There's a lot of extra stuff in your handout from your staging and prognostic factors, different patterns, and also added in a few different extra entities to help with forming your differential. And that's what we have for you this week on slide review. So if you like this video, give it a thumbs up. If you're unsubscribed to us, hit that subscribe button so you can be notified when we have new content out. And we will see you next week with another slide review.